Okay, I'm going to introduce our last speaker before lunch, Katherine Sharpe. She's here to speak about the voice of the patient. Katherine Sharpe is the Senior Vice President of Patient and Caregiver Support and has been with the American Cancer Society since 1997, serving most recently as Vice President of Health Systems for the South Atlantic Division, where she's provided leadership for the vision, direction, and strategy for health systems, including mission deployment through primary care hospital and state-based systems. As the Senior Vice President for Patient and Care Support, Katherine provides strategic direction to the Society's patient and caregiver support, as well as post-treatment survivorship initiatives, overseeing strategic, integrated, comprehensive planning for and execution of patient, caregiver, post-treatment survivorship initiatives at all levels of the organization, and ensuring initiatives are evidence-based, regularly evaluated for impact and quality improvement, and consistent with the patient support survivorship goals and objectives set by the National Board of Directors. Katherine previously served as the Society's Managing Director of Prevention and Survivorship Strategy, where she provided key leadership in establishing the National Cancer Survivorship Resource Center. While in that role, Katherine led a team that facilitated the development of clinical guidance for post-treatment survivorship care, developed strategies to enhance provider and survivor education, and established survivorship as a priority for a public health policy. Prior to her tenure with the American Cancer Society, Katherine worked as a case manager and a counselor in a variety of clinical settings, including Children's Medical Center, Dallas, Texas, the Scottish Rite Hospital, Dallas, Texas, and Austin State Hospital in Austin, Texas. Thank you.
Thank you all so much. I'm really excited to be here today. This is the decidedly non-clinical part of the presentation today, so I hope you learn a few things from what I'm going to talk about. I apologize, I'm getting over a cold. I'm not contagious. My voice is a little less than 100%. I want to talk about a different type of toxicity, and that being financial toxicity, and I think everyone is probably pretty familiar with this, given the work that you do. But obviously, how we care for our patients is really a reflection of who we are as a country. And, you know, it's not always the situation in which we can give everybody a chance. We've heard some talk today about access issues from benefiting from all the advances that have been made in cancer therapy. And we know that some people just can't afford or access the care that they need. And unfortunately, cancer is the leading cause of medical bankruptcy. So we're going to talk a little bit about financial toxicity, and I realize I'm standing between you guys and lunch, but I talk fast, so I promised I'll have you out of here on time. I think that this is such a revolutionary time in cancer and cancer treatment. But part of the work that we do as an organization is really trying to ensure that everyone has access to timely, high-quality cancer care. And I think that that's why all of us are in the jobs that we're in. We're trying to help people get well and stay well. Part of what we see at ACS, though, the people that contact us, and we get roughly 1 million calls a year at our National Cancer Information Center. We get tens of millions of individuals visiting our website. These are generally individuals that are really struggling with accessing care. And so I'm going to talk about a couple of ways that we work to better support patients, both on a national level and then also on a community-based level. But first, I always use stories, because I like using stories. They're more interesting. This is my brother-in-law. His name is Tom. And in 2004, he was diagnosed with a stage 4 head and neck cancer of his unknown primary. I use the story because it's an example of how quickly the dominoes can sort of fall. He worked for a very small landscape company. He was not able to work, so he didn't generate a paycheck. Unfortunately, his company closed, and it was so small that it didn't offer any continuation of healthcare benefits for him. So then suddenly he finds himself mid-treatment without insurance. Trying to access resources, of course, is always challenging. And so he benefited from the fact that the family was able to help support him through the remainder of his cancer treatment, but he also skipped appointments, skipped meds. I mean, it clearly impacted his quality of life, and having a head and neck cancer is not a walk in the park to begin with. I'm happy to say, though, he's a happy, grumpy old man living in Florida now, and he's been cancer-free now for over a decade. So, but it just shows you how close you can get to the edge when you have a cancer diagnosis. I think everybody's familiar with the definition of financial toxicity. This is something that's really bubbled up in the literature, particularly over the past, I don't know, say 5 or so years, and really looking at how individuals react to financial challenges within their cancer treatment. And as noted in the second, not bullet, but second statement, is that these are impacts that can actually impact the quality of life and even the survival of cancer patients. So we all know the cost of cancer care are rising. We've been talking about that this morning. These are not inexpensive therapies. And even outside of CAR T, you're seeing increasingly expensive targeted therapies, immunotherapy. So patients are receiving these new expensive therapies, and then prices are not uncommon to see them in excess of $10,000 a month. But we know on the flip side, we don't want to discourage innovation either. We know that the development of these new products is also an expensive endeavor. But we're really seeing these costs increase. Again, you look at some of the numbers from almost 125 billion in 2010 to pushing 160 billion by 2020. And one of the things that we've really seen a lot at ACS lately are these third-party payers shifting the cost to patients. I think probably all of us have experienced that as well. And the average out-of-pocket cost really now range from about $1,700 to almost $5,000 annually. What we're seeing is that people pick the insurance plan that they can afford at the time, right? I mean, it makes sense. They don't read through all of the fine print. I don't know if any of us really do, though I do keep an eye on it a little bit more now. But what they do is they don't realize then the impact of that policy when they get a cancer diagnosis. And so they'll contact ACS saying, I can't afford this. I can't afford these out-of-pocket costs, and I don't know what to do. And so part of our job is sort of weaving together the somewhat scant resources that exist out there and helping them, meet their co-pays and working with other organizations to help mitigate some of these costs. But we know that, almost 50% of these U.S. health insurance plans are really these high deductible plans, and that's what we're really seeing with our patient population. Even with those, again, with insurance, and we still see people that have no insurance, this financial distress is pretty prevalent amongst the patients that the American Cancer Society serves. Then you also see this compounded by ongoing cancer care, in particular for cancer survivors. You see a lot of the challenges around paying for long and late effects of their cancer treatment. Again, I use my brother-in-law as an example. I mean, he had a radical neck dissection. He still has a lot of late effects from his cancer therapy. And these are things that obviously cost money to manage. A lot of folks often, too, think that, this is just sort of their new normal and even avoid seeking treatment to better manage these long and late effects. Limited workability. There was a comment made earlier today about those that are unable to return to work because of their cancer treatment or cancer diagnosis. Very common. And that obviously impacts individuals even further in terms of their ability to pay for their care. You see people that are clearly at increased risk for financial toxicity if they're bringing another comorbid condition. We know that most cancer patients generally have 1 to 3 comorbid conditions, so it's pretty prevalent within cancer treatment. Certainly those with any existing debt, a loss of income. And you look at, a lot of the information that's published about the typical American and how much money that they have in terms of savings, it's virtually none. And so you see, again, sort of that very easy catastrophic domino effect that often occurs. So what are the consequences? Well, we know that individuals that are dealing with financial toxicity, many of them are likely to declare bankruptcy. As we talked about earlier, cancer is one of the leading causes of bankruptcy. We know that it was a recent study in 2017 that almost 80% of cancer patients report some sort of financial burden, from moderate to absolutely catastrophic. In terms of survival, again, those that declare bankruptcy almost 2 times more likely to die than cancer patients with the same diagnosis and treatment. And interestingly, looking at Medicare data, when you're looking at, this study looked at 20 million cancer survivors, they saw that almost 30% had significant, I would say put this in the catastrophic category, from bankruptcy to not being able to pay for medical visits. There was actually some additional data that showed 1/3 of Medicare patients that were prescribed Gleevec, within the first 6 months of that prescription being issued, they didn't fill it. They couldn't afford it. So that's 1/3. And then when you start looking at these numbers, and this is part of what I love about working at ACS, because we can look at it on the individual level and then we can look at it on the macro level, is when you look at the individuals that are reporting this type of financial distress, you're probably talking about annually or close to 200, maybe 400,000 people that are unable to make all of their appointments, get all their prescriptions filled, they're taking half doses, they're skipping doses, so it's very common. And obviously they feel guilty about it. So part of it is our ability, I think, to have a conversation about where that patient is and what their realities are. Some of the patient perspectives, I've mentioned some of these. For ACS patients that do have coverage, most of them have inadequate coverage. It's just not enough to cover their cancer diagnosis. I've talked about the fact that their copays and coinsurance are unaffordable, that gets problematic, and then it can get catastrophic. I think Dr. Mahoney, who was before me, mentioned some of the insurance issues, and this has been a fascinating thing to watch. With CAR-T, some of the biggest challenges or issues have been just around insurance. Particularly Medicare and Medicaid trying to figure this out, and we know that currently coverage is often kind of on a case-by-case basis. I think we've talked about some of that today, is really looking at that patient, what works best for them. There's a lot we have to sort out here, and this is so new. So some of the specific challenges we see around CAR-T and insurance and payment issues. We know it's life-saving, but it can also be very, very expensive. I know the comment earlier about $450,000 life-saving drug. It's great. I mean, I would want that as much as anyone else, but how do you pay for it? The other thing that was mentioned earlier is just some of the related costs around CAR-T. We know that, we've heard about the toxicities. We know that it results in intensive care stays. We know that individuals often need to stay within the area, and we know that CAR-T is only offered in certain geographies now. So individuals needing to stay in an area, that brings additional cost around lodging and transportation, and many patients just don't have those resources. And then we know that these hospital stays can go from a week to a month and potentially even longer. It's interesting to look at this, and it's, from an ACS perspective, we've worked with many patients around stem cell transplant, and those are the individuals that generally had to be in hospital, and so we've built a lot of support for those individuals, and I'm going to speak to some of that in a minute. But I think that we're really moving to looking at where CAR-T is being offered and how ACS can help you in the life-saving work that you do every day. Excuse me. So how do we begin to move forward? I love this meeting because I think this summarizes what this slide is saying. It's really involving everybody to figure out how do we overcome some of the barriers to care. We've talked about issues of access. Can everybody access CAR-T therapy? Is it a geographic barrier? Is it an economic barrier? Are there other barriers that these individuals experience, and how do we help overcome some of these barriers to care? it's kind of the wild, wild west right now in terms of, oh, thank you so much, in terms of payment. So it's something that I think that we're going to continue to look at, and how we can, again, as a village, we've talked about that a lot today, how do we begin to solve for some of the insurance and coverage challenges. One of the, a recent article from the American Journal of Managed Care talks about that, the arrival of these types of therapies are really going to mandate payment models that are really almost as novel as the medications themselves. And again, I think this meeting is reflective of it. This is going to take time, and it's going to take really broad institutional involvement. I think today's meeting is structured in such a way that we're seeing, how supply chain, pharmacy, supportive care, all of these components need to come together to optimally support the patient throughout this process. One of the things I think that we do have in our advantage, and this is a little hard to read, I'm not super good with PowerPoint, is just some of the access programs that the manufacturers provide. I think that that's one of the silver linings that we can see right now, is that there is a high degree of hand-holding for patients as they go through this process, not only from treatment support, but also patient support, how to better coordinate care. So I think we've got some advantages that are occurring there. I think that part of this is really looking at that shared decision-making as well. I've talked a little bit about the value of communicating cost and having conversations with patients around this. One of the things that came out of the IOM quality care publication is patients really want to understand not only about their diagnosis, but tell me about the risks and benefits, and tell me about the costs that are going to be involved with this choice. But we know that there are challenges. There's also a lot of reluctance to talk about the cost of care. We may not always know the total cost that patient may encounter, and then there are time constraints as well from a provider perspective. So let me shift a little bit, and I'll talk just for a couple more minutes about ways in which ACS is working to help solve for some of this. We are really, really committed to patient access. I can't underscore that enough. A lot of the work that we did as an organization prior to the implementation of the Affordable Care Act was trying to help inform the development of healthcare reform. We took patient stories that we had received and used those from a policy perspective. So really illustrating to legislators what are the issues that cancer patients are experiencing. I just saw in the news today that ACS, our policy arm, the American Cancer Society's Cancer Action Network, they actually, along with many other patient advocacy organizations, filed an amicus brief today in a case in the U.S. District Court, which is seeking to eliminate the ACA, and in particular the pre-existing condition component. And so ACS has been deeply involved with trying to preserve the Affordable Care Act and ensure that patients can continue to receive the care that they need. So know that that work is going on simultaneous to our work as an organization. Again, I mentioned it earlier, really trying to help patients access the care that they need. So I'm going to highlight a couple of things just in case you guys aren't aware, resources that may be available, not only obviously to your CAR-T patients, but other patients that you might see within the clinical setting. We did begin a service that helps patients navigate through their health insurance options, cleverly named the Health Insurance Assistance Service. We started this in 2005 just to help patients find coverage options, and then we navigate them to other resources that can help them with copay, debt mediation appeals, off-label use, et cetera. We've actually started this year a pilot program in certifying financial navigators. There's an increasing body of evidence about the value of financial navigation, and we continue to look at ways to expand this program. This is actually being supported by the Robert Wood Johnson Foundation. They're very interested in this model as well. Some of the other resources that we've had since pretty much feels like the dawn of time, we are very committed to helping patients get to their treatment. We have transportation resources that we provide, both our Road to Recovery program, which is a volunteer driver program. But we're also working with Lyft, other ride-sharing companies, use cab vouchers. I mean, we kind of, again, cobble together what we can to help patients get to their treatment facilities. We also, well, I'll talk about this. So just in 2016, we provided over 300,000 rides to cancer patients. Lodging, and this may be more relevant for CAR-T, is that we work very hard to make sure that patients have a place to stay if they have to travel for treatment. So I'm sorry to say we do not have a Hope Lodge in Seattle, but who knows? For those that are here from Memorial Sloan in New York, we do have one in Midtown Manhattan, however. Hope Lodges are an ACS institution. We've got over 30 lodges across country. These are places where patients and their caregivers can stay free of charge for as long as they need. So again, a good fit, I think, for CAR-T, maybe looking at going forward, how we can align our lodges more with the sites that are offering this therapy. But while we have a finite number of Hope Lodges currently, we do have hotel partnership programs. So the most notable one being with Extended Stay. And so we've partnered with Extended Stay, and they have provided over 50,000 free nights for patients that have come through ACS that need lodging options. So in 2016, over 500,000 nights of lodging. We've saved patients and their caregivers almost $50 million as a result of that. So again, very practical types of solutions, but ones that we know have benefited our patients over time. So in summary, I just want to say that I think we've seen a lot of progress in cancer treatment. There's so much great work being done to make sure that patients can access these life-saving treatments, but there's a lot of work remaining. But I think that dialogues like we're having today, and I'm excited to hear some of the perspectives that will be brought in this afternoon and certainly tomorrow, it shows your commitment from being here in the room that we're all trying to make this as easy for our patients as we possibly can and helping them access some of these life-saving therapies. Some of the data that have been presented today are remarkable. You know, as somebody who grew up in the 70s and watching, you know, a cancer diagnosis being, for so many, a death sentence, to see some of the advances that we're making today is remarkable. And I commend each of you for the life-saving work you do. I mean, truly, you are all angels, and it's an honor to be part of the discussion today. So I'm going to stop, see if there's any questions, and if not, lunch looks really good. Thank you.